Relief of right ventricular outflow tract obstruction on cardiopulmonary bypass. A midline sternotomy incision is made. A patch of pericardium is arrested if a patch enlargement is expected to be required. Bovine pericardium or a cortex patch can also be used. The pulmonary trunk and the aorta are separated from each other by sharp dissection so that the aorta may be cross-clamped without impinging on the pulmonary artery. The aorta is cross-clamped because there is an ACD. The usual techniques for cardiopulmonary bypass are used. Hypothermic cardiopulmonary bypass is initiated. The degree of hypothermia depends on the expected length of the procedure. If a patent duct is present, it is closed. The aorta is cross-clamped and the cardioplegic solution is infused into the aorta. The left side of the heart is vented either across the atrial septum or by placing a thumb sucker into the opened pulmonary artery. Pulmonary valvotomy, valvectomy. A vertical incision is made in the proximal main pulmonary artery. The incision is carried down into the anterior sinus of falsa valve. The exposure is facilitated by the placement of a small nerve root retractor in that sinus. The anatomy of the valve is inspected. If the valve is tricuspid, the fused commissures are incised sharply with a knife. If the valve is bicuspid, it is often necessary to detach the cusps from the lateral attachments to the arterial wall to obtain a satisfactory relief of obstruction. The detachment of the cusp from the arterial wall is done both in bicuspid and tricuspid settings. Now we are going to see figure 28.5. This is the figure of 28.5, and you see how the big bicuspid pulmonary valve commissures is cut by 11 blade. Some degree of incompetence will inevitably result from this maneuver. If the valve cusps are bulky and obstructive, valvectomy may be necessary to relieve the obstruction. The pulmonary arteriotomy incision is usually closed directly with a continuous suture of fine polypropylene. In the upper picture, you see the figure 28.6, and in the more difficult valves, they has incised all the valve. If there is a concern about the size of the pulmonary artery, a patch of pericardium is used. If the atrial septal defect is to be closed, the caval snares are tightened and the right atrium opened. The left heart is allowed to fill with blood and the interatrial communication closed either directly or with a small patch. The right atrium is closed, the aorta is unclamped, and the heart is there. Secondary infundibular hypertrophy is a common cause of residual gradient between the right ventricle and the pulmonary artery. It is sometimes difficult to decide whether an infundibular resection with or without patch enlargement is necessary. In the setting of biventricular repair, a small dose of propranolol can be given intravenously when the right ventricle left ventricle pressure ratio is greater than 0.75 or when the right ventricle pulmonary artery gradient is greater than 50 mm mercury. This maneuver can identify patients in whom the residual gradient is reversible and those who need further surgical relief of the obstruction. Intraoperative echocardiography may also be useful. Infundibular resection. A transatrial transpulmonary approach can be used initially and only if access is adequate is the right ventricle opened. The right ventricle is opened through a transverse incision which is closed directly or alternatively through a vertical incision which is usually closed with a small patch. A vertical ventriculotomy allows for extension across the pulmonary valve annulus if transannular patching is required. Infundibular obstruction is most commonly due to hypertrophy of the parietal and septal extensions of the infundibular septum. The hypertrophied muscular bands are widely excised. The resection usually starts on the septal limb, taking care to remain fairly superficial to avoid perforation of the septum or injury to the septal branch of the left anterior descending coronary artery. Passing a clamp behind each hypertrophy mass before transection shows that the ventricular septum is neither thinned nor perforated. Figure 28.7. This is the picture when you will cut the muscles in the infundibular septum, infundibular of right ventricle, and before excising it you should pass the clamp and then incise it. The base of the medial papillary muscle of the tricuspid valve may attach to one of the hypertrophy septal bands, and care must be taken not to transect it. The parietal wall of the right ventricle is mobilized in a similar fashion, extending the resection as far caudally as the papillary muscle of the tricuspid valve. The infundibular septum itself may be trimmed when it bulges into the flow of the outflow tract. When the infundibular resection of the right ventricle is carried out from the right atrium, the parietal extension of the infundibular septum is situated superiorly and can be approached inferiorly with an angled clamp so as to transect it from the infundibular septum and the free wall of the right ventricle. Relief of mid-right ventricular obstruction, double chamber right ventricle. This intraventricular obstruction is situated between the inlet and the outlet portions of the right ventricle. It is usually, but not always, associated with a small or moderate large ventricular septal defect. The repair is done on cardiopulmonary bypass with bicaval cannulation. The examination of the heart may reveal the presence of a thin wall distal chamber. There is often a branch for the right coronary artery that crosses over the underlying obstruction. The obstruction can often be relieved via a right atrial approach. The ventricular cavity is explored with the tricuspid valve entering the proximal chamber. The muscular obstruction in the roof of the chamber often relieves a small circular orifice covered with fibrous tissue. This looks very similar to a small ventricular septal defect. However, a ventricular septal defect tends to be situated more leftward and inferior and may bound onto the tricuspid valve. Gentle probing of the opening will reveal connection with the distal chamber. Resection, initially starting anterior and to the left of the opening, will start to open up the connection with the distal chamber, taking care not to divide the papillary muscles of the tricuspid valve. Alternatively, the resection of the obstruction can be done through a transverse right ventriculotomy immediately above the site of the obstruction and of the coronary branch if present. The appearance of muscular obstruction in the bottom of the infundibular chamber is illustrated in figure 28.8, often very similar to a small ventricular septal defect. The tricuspid valve, which is situated upstream to the obstruction, cannot be visualized, and this indicates that the orifice is not a ventricular septal defect. An incision is first made into the obstructing muscle anteriorly and to the left. This allows one to see the proximal chamber of the right ventricle and the tricuspid valve apparatus. The resection is then completed, taking care to preserve the papillary muscles of the tricuspid valve. If present, the ventricular septal defect is then closed. The right ventriculotomy incision is closed directly. This is the image of right ventricular outflow tract obstruction and also double chamber right ventricle, and this is the band how it excised, and the obstruction has relief in the right ventricle outflow tract. Thank you very much for your listening. See you in another micro theme.